So we can go ahead and get started. First of all, hi everyone and welcome. I want to first introduce myself. My name is Blair Davis and I'm the Director of Alumni Engagement for the School of Arts and Humanities here at UC San Diego. And I want to thank you for joining our virtual session of the Triton Leaders Conference on health policy. And today's session is part of a larger event and a larger conversation that will continue tomorrow at UC San Diego's Park and Market location in person downtown. And over these 2 days, Triton leaders will come together to discuss building an equitable future in healthcare. And for today's session, we are fortunate to have with us Amber Campbell, Geoff Hollett, and Imani Howard, who have dedicated their work and research to exploring key ways that gender, race, and access intersect in healthcare policy. So before I begin, I want to give you a little bit of a roadmap of how our session's going to go. And first, we'll hear from each of our panelists. And then we'll have time for questions after that. And you can ask those via the chat. So we'll be keeping an eye on that. And so to get us started, I'll go ahead and introduce our fabulous panelists. Amber is an executive in healthcare administration and an advanced DBA candidate at the California School of Management and Leadership at Alliant International University. And she's researching gender disparities, the role of women in healthcare. Her professional equity work includes serving as the liaison to the Justice, Equity, Diversity, and Inclusion Committee for California's Association of Healthcare Leaders. And she's also an author of a book entitled Fierce, The Power of Owning Your Own Journey. Geoff holds a PhD in material science and engineering from UC San Diego, where he developed birth control products for women in sub-Saharan Africa. He then moved from research into policy, where he became a Science and Technology Policy Fellow with the California Council on Science and Technology, serving as the policy advisor for California State Senator Bob Archuleta. Geoff is now a senior science policy analyst for the American Medical Association, where he develops policy on precision medicine, medical disinformation, and emerging areas of science and technology. And Imani is a trainee in the Medical Scientist Training Program here at UCSD and is also pursuing a PhD in philosophy, where they're studying at the intersection of the philosophy of race and the philosophy of science and medicine. Imani's research considers the ways in which scientific reasoning and clinical decision-making with regard to race shapes patient populations and impacts patient health outcomes. So we have very, very impressive panelists. We are in good hands for our conversation today. And I'll go ahead and pass it to Geoff to get us started.
Thank you, Blair. So as said before, I am a PhD scientist from UCSD. I graduated in 2019, the material science background. And as you may imagine, my journey through the policy space is a little non-traditional. So prior to coming to UC San Diego, my research was in things like prostate cancer, nanomedicine, or I even spent some time working on catalytic converters for diesel engines. And we can sometimes trick ourselves into thinking as engineers or as researchers in the STEM fields that, we can research our way through our biggest problems. So for example, the conversations we were having is, if we make the perfect catalytic converter, we will solve climate change. We'll clean up our air. Or with the prostate cancer research, if we make a good enough drug or particle, then we'll cure cancer. But when I came to UC San Diego, the project that I started working on was quite a bit different in terms of its framing and also its outcomes. I was working on birth control research for women in sub-Saharan Africa, a population that I wish I knew more about coming in, and a problem that turned out to be incredibly important. If you want to move to the next slide, I just want to briefly touch on why I think about health policy in terms of science and technology as so important and such a critical step. So we often describe birth control as, one of the greatest medical innovations that's happened in the last century, and one of the leading ways in which we've empowered women and expanded access in society. But if we actually look at what happened to women enrolling in things like medical school and law school, which is here what's on this graph, this is the proportion of men compared to women compared to men for first-year students in law, medicine, dentistry, and business schools. We can look at the trend over time, and hearteningly, we see it going up. But if we actually look at what was going on the technology and on the science side, in 1960, Inovid, which was the first birth control pill, was approved by the FDA in 1960. But you see that there's at least a decade in the trends for women enrolling in higher education before there started to be an uptick. So there were a lot of things socially going on, I'll concede, but also there was a lot of policy going on. So in 1965, you may be familiar with the Supreme Court case, Griswold v. Connecticut, where there were laws on the books that women could not use birth control. It was illegal for women to use birth control in many states. And the 1965 court case, Griswold v. Connecticut, overturned those laws for married women. And it wasn't until 1972, in another Supreme Court case, Eisenstadt v. Baird, where all women, not just married women, could legally use birth control in all states in the US. And it is only then when we started to see an increase in women, being able to be more proactive family planners, be more proactive in control over their lives, and be able to enroll in school and not have to worry about family planning or what happens if they get pregnant and so on and so on. And I began to see these problems starting to pop up all over the places that, the technology existed in 1960 to solve this problem, to make family planning more accessible, to make women have access to the same degree that I would have had if I was enrolling in school in 1960. But there were laws in place that prevented them from doing so. And we see that all over the place and is a huge barrier for preventing true progress to be made, especially in the field of health equity. So after I finished my PhD, I then moved to the California State Senate, where I was working for a legislature, Senator Bob Archuleta, and he represents a majority-minority district in Southeast Los Angeles County, so serving 1 million Californian residents southeast to LA. It's nicknamed the Diesel Death Zone because of the sheer number of diesel trucks that drive through the district from the port of Long Beach. The air quality is terrible there. It has some of the highest rates of childhood asthma. But there are trade-offs. Do we move to electric or hydrogen-powered vehicles at the expense of roads, or the cost when the cost could be used to invest in other things? There are trade-offs to make those decisions to improve the health of the residents of the senator's district. But also there were things that we also had to consider about the way in which health inequity spreads, is that, oftentimes there may not be data that we can use to support it. So for example, there was an animal fat rendering facility in the senator's district or nearby, where they melt down animal fat for developing soap and other products. That doesn't show up on an air quality report, but the smell is terrible. And so people are discouraged and disincentivized from going outside and exercising and enjoying nature and, enjoying their neighborhoods. Exide, a plant that had severe lead poisoning, was in the district, but the district was thankful that Exide was there before they learned about the lead poisoning, because it meant good jobs and good access to health insurance and things of that nature. So there are these really complex problems that technology doesn't always solve. I think that's kind of sort of funny to say in retrospect, having sort of been on the journey that I've been, but I really want to emphasize is that as an engineer by training, I tricked myself into thinking that I could solve some of the largest problems without thinking about the structures in which they operated in. And I'm excited to see what you all have to say, and I'm excited about the conversation, and I'll turn it over to Imani.
Hi, everyone. Can you hear me? I think it's all good. Okay. I am happy to be here. My name is Imani Howard. I am currently an MSTP trainee. So I am at UCSD doing both a medical degree and a PhD in my PhD is in philosophy. It's a little bit of a non-traditional PhD for this program, but I have very significant interest in the philosophical side of medicine, and I think that there's a lot of unanswered questions there. So while Geoff talked about things like technology and policy, which are obviously super important, I'm going to be talking a little bit about like kind of professional culture and understanding, and what it means when doctors talk about race. So I also wanted to make this talk like a little bit helpful because I know that people are really unfamiliar with philosophy in general, and that it's kind of a difficult field to crack into if you're not familiar. So I kind of just wanted to give a little bit of, philosophy background that's hopefully interesting and gives a little more perspective on the questions that I asked. And so I'm going to be talking about the phrase race is a social construct, which I think it's one of these phrases that has like escaped theory, right? Like theory is like here doing its thing, and then it kind of ran away into the public. And so now it's like running loose. And I think that a lot of times people have a difficult time like getting a handle on what that means or what it might mean. And that's exactly because, right, it tends to come as this kind of like unit of a statement outside of its like original context. And so hopefully you're going to situate that a little bit for you guys. So first asking the question, like, what does it mean for anything to be a social construct, right? Like there's things that you might think are social constructs that are like obvious to you, like maybe money or something, or, the building that I'm in or something like that. So these things that you say, well, it's obvious that, society constructed them and, they're maybe not like real, right? We don't necessarily, we can say money's not real, but maybe I need it or it's real or it's, fake in a certain way. And so the theoretical way to think about social constructionism is not necessarily a distinction between real and not real, but kind of inevitable and not inevitable. And so I have a definition here next, yes. So what it means for X to be a social construct is that X doesn't have to have existed or doesn't have to be at all as it is. And so when I say race is a social construct, I don't mean race is not real, race doesn't exist, I don't see race, I don't mean any of those things. I mean, it's the way that it is, the way that we think about it, the way it operates in our world is not necessarily the way it had to be, right? We could have rolled the dice on society and ended up with a totally different set of groups, and a totally different, way of looking at the world or classifying people. And so, next, please. Awesome, right. So the common interpretation when you hear if race is a social construct is that, okay, race is, maybe it's real, but it's not biological. And this is kind of where I think a lot of social sciences folks and medical folks stop talking to each other, because in biomedicine, we treat race as this kind of partially biological thing, we think about it very much so in a biological lens and through things like genetics and ancestry. And so the problem that I identify in my research is really that these two are talking past each other. There's social components to what we're talking about. Obviously, there's biological components to what we're talking about, and they interact to form the group that we are interested in, right? Or the groups that we're interested in. So next, this is a diagram by, oops, keep going. Oh man, okay, sorry. So this is supposed to be next, but it got out of order. Sorry about that. So Ian Hacking is a philosopher who did some period at UCSD working here. He also has been all over the place. He's kind of like the social constructionist. And he describes this looping effect where a label for a group has a really significant and tangible impacts on the group that is actually being referred to. And so if you can imagine, right, if this is a good example maybe from education, right? If I group these students and I call them underachievers, right, or I track them in a certain way, then that impacts the group as the group moves on, right? It's not going to stay the same group because the input of being an underachiever makes them just socially has the tendency to cause downstream effects that changes the group. And so the group then gets these other features that are drawn up into the label. And so it's this cyclical relationship between the way that we talk about things and the way that we refer to groups or people or kinds or whatever, and the groups themselves, because when you talk about someone, they're not passive to that, right? People react to the way that they are classified, to the way that they're talked about, to the way that people perceive them. And so due to looping, the social and biological elements of race can't be isolated from one another in the sense that we in biomedicine really like to, isolate and change and, break in a way that makes them easy for us to understand and then actualize these kind of measures to adjust. And so one example of that in the US would be African Americans as a group, right? And so it's very obvious that, before 1619, it didn't make any sense to call anyone an African American. It just wasn't a label in common use. In the early days of US chattel slavery, right, it's really a social designation. It's you over here, right, you over there, and people are constantly coming in from different places, from the Caribbean, from, sometimes even as far as Southeast Asia, and they're getting lumped into this group, African American. Over time, though, that has real impacts on the group. And so today, people who are labeled African American share enough ancestral DNA to be grouped via these kind of, the ancestry and almost an ancestry and me, but you know what I'm talking about, ancestry.com, 23andMe, those kind of programs, can identify, hey, you are descended from this group of people who migrated into this area very recently, right? And so you can see how very quickly something that is not even a label in existence can lead then to a distinct ancestral population that has significant, needs in that context. Obviously, African Americans also have significant needs within a social and environmental context and support that's needed there, right? But there's also, DNA. I mean, sickle cell is the big example, but there's real impacts of these groups being formed and being labeled and being change over time in that way. And so this is how I'm trying to kind of tease apart and maybe one day suggest a better system for us as physicians to really think about race and how we understand then racial health disparities. So a lot of work is done on trying to differentiate health disparities that are socially driven, right, from health disparities that are biologically driven. And kind of at the crux of this research is that that's going to be really, really not possible to do, and that both kind of need to be tracked independently within the same paper, so not independently, but dependently on each other. And so I'm gonna, forthcoming details and examples of how that works out. But yeah, and also feel free to ask me any questions in the Q&A. I am all finished with my slides, so I'm gonna pass it to Amber.
Thank you, Imani. I love so far how we each are looking at, obviously health equity from these different lenses of research and policy. And, for me, it's actually, I'm really honored to be in kind of two spaces, which is the administration, working as a healthcare executive, but also right now currently as a researcher. If you don't mind just hitting next on the slide so that the whole thing shows up, I would appreciate it. So let me tell you a little bit about both of the lenses at which I look through this particular problem. First and foremost, I was a grad, my undergrad was at UCSD in 2004, a very proud Earl Warren College Arts and Humanities graduate. So really love being able to come back today and just meet with all of our fellow alumni who took the time out of their busy Fridays to join us on this particular call. So thank you for that. I'll tell you a little bit about me as an administrator. I do work in a healthcare delivery system here in Northern California called Sutter Health. And on a day-to-day basis, I have operational oversight over many areas in which health equity and really access to equal health care is a significant focus. So one of those areas is behavioral health or mental health services. I think it's no surprise to anyone that those services are having dramatic access issues. There's not enough clinicians. There's not enough real-time access. There's a lot of really great people who are passionate about it and are trying to do different things to bring that technology, to the forefront. But as an operator who has actual clinicians in the clinic seeing patients every day, there's a lot of work that we're doing across the 3 counties that we service here in Northern California to try and bring more access and more clinical teams to our behavioral health needs of our community. I also oversee the oncology service line. So, I'm sure some of you who got to see the keynote speaker earlier hear about, how health equity is showing up in the cancer space. Certain groups are obviously more affected by outcomes, and a lot of that has to come to play with screening, right? Our ability to screen and catch cancer early so we can actually, keep people from late stage disease is all dependent upon our outreach to our communities. So there's a lot of work that we do specifically setting up free cancer screening events in lung cancer, breast cancer, prostate cancer, et cetera. So we can try to address those inequities in our own communities. We also do distress screenings for those same cancer patients for their mental health as well to make sure that, we're addressing, again, the psychosocial aspects of that care. And then lastly, trying to get to the preventative space, which I think all of us would like to see in healthcare. And that is, how can we identify that you're high risk for cancer or cancer genetics and really get that out? And that's really a current project that we're in right now to try and get more cancer genetics education and screening out into the community so we can catch things in patient populations that are higher risk for that disease state. So I do work within a larger system. So while I have just 3 counties for my oversight, I work for, a system that has over 24 hospitals and 7 medical groups and foundations. So we thankfully have a larger corporate system that helps us to support the health equity work that we're doing here in Northern California too. And that looks like, supporting our local food banks, because we understand that healthcare is not just about the access to care that you receive when you go to a clinician's office or a hospital, but also, are you eating healthy foods? Are you getting your exercise? And how can we as a healthcare delivery system show up in our communities in those ways? So like I said, partnering with our food banks, partnering with our local schools and our community health providers to make sure that we are extending out beyond the actual delivery system that we do today. So that's just a little bit about how I help with health equities in my own area of purview as an operator here in healthcare. Blair was very gracious in reading my bio, but the other things that got me really passionate when I got into healthcare was really around the workforce. So we think about healthcare as an industry that, in my opinion, should be leading the ways for gender equity, right? And women are 75% of the workforce in most areas, and yet we are less than 4, 10, depending on your health system, % of the C-suite in the boardroom. In my opinion, we should be the leaders of a best practice, if you will, for gender equity at all layers of our organization. And so I got really involved in standing up our first ever women's inclusion resource group and finding ways in which we could create inclusion councils, and then also the California Association of Healthcare Leaders, that justice, equity, and diversity inclusion work, because it's not just about obviously gender equity. There's lots of other components, as my fellow colleagues shared. But one thing that really sat with me is thinking about, why aren't women at the table, right? And that kind of, for those of you who've heard the quote, right? Diversity is having a seat at the table, inclusion is having a voice at the table, and belonging is really feeling like your voice is heard. And I think that's where women have struggled. Some have been able to make it to the seat at the table, but unfortunately, because of benevolent sexism, they're associated with, well, can you take the minutes? in this room, or can you go grab us the coffee? And they finally got there, and yet they have to be quote unquote part of the good old boys club. And then, secondarily, we don't want tokenism, right? We don't want to check a box and say, hey, we've added a female to our board, or we've added African-American to our board. That's not what anyone wants to solve for. We want equal opportunity and the best person and the talented person for the job, but that starts way upstream. That starts with identifying talent early on. That starts with developing talent. That starts with providing early opportunities for people to actually get the development that they need to move into whatever position they would like to see. So as I headed into my doctorate program that I'm currently in, this was something that I decided was going to be the focus of my research, and specifically that gender equity issue that I believe exists in healthcare leadership. The stats that you see on the screen are really from the McKinsey & Company Women in the Workplace study. It comes out every year. It's a wonderful study for those of you who haven't seen it. It's really robust. This is just one little tiny infographic from that, but you can really see that over time, while there's been some improvements, there is still racial disparities within that. There's still not enough movement when we get past that VP or senior VP role into the C-suite. And really, a lot of what I would call the people who have inspired me, or the public figures, if you will, like the Melinda Gates and the Sheryl Sandbergs of the world, have focused on gender equity issues with regards to pay, which is still an equal, an important part of this problem. And then, our lovely RBG, and making sure that policy and law match that. But while lots of research has been done in those other spaces, they haven't really focused on what really keeps women from promoting and moving forward. I would be remiss if I didn't stop and say that today is National Women's Physician Day. So yes, we have a day on the calendar where we can recognize the clinicians in our world that are female. But women spend 8 to 10 years going through medical school to finally become a physician. They put their lives on hold. And by the time they get to that final spot where they're actually able to deliver medicine, they want to get married, they want to have children. And then they put that other part of their component of maybe taking on additional committee work or taking on leadership roles, and that gets held. So we don't see a lot of physician leaders who are women. We don't see a lot of administrators who are women. And so just, again, very passionate about what are those barriers that we overcome? I'm literally in the middle of a qualitative research study as we speak, interviewing people about every other day to try and seek to understand really the root cause of this problem, and hopefully inform some action-based research as we go forward to how we can make sure that healthcare, specifically as an industry, has a chance to show up as a role model in the gender equity space. So I'll leave it with that and turn it back over to Blair, because I think we're going to have some really great discussion about each of our areas.
Thank you, Amber. Thank you all. I am so moved by the work that you're doing, and the way that you are tying together structural conditions that exist, and talking about different disciplines talking to each other, and all of those things. And I really applaud you all for the incredible work that you're doing to give us a much more comprehensive picture of this issue. So I want to kick off the questions with a question for Imani. And this is a question: what motivated you to get into your research area? What experiences did you have that informed your passion for advocacy?
Thank you. That's a great question. Wow. I would definitely, there's one end, right? That's like academic interests. I've always kind of been interested in philosophy and reason and logic and those kinds of things. And coming into medicine, realizing that a lot of those skills are kind of on the back burner for just other industries. And so I always was fascinated in philosophy as a discipline. But as far as advocacy and racial justice and things, it was really the process of going through medical school. So part of my research is focusing on medical education, and physicians learn very perplexing things about race. And I don't necessarily want to terrify anyone, so I won't go into a whole lot of detail, but there's not a lot of consistency in the way that physicians are taught to understand race and to treat people who get labeled with certain racial labels when they come into the clinic. And so I think that there's a lot of work, right, working on implicit bias and, these kind of more interpersonal instances of racism and racial mistreatment, but the explicit ways that race is handled in medicine was just really, really confusing to me. And it's confusing because there's not really a coherent theory. Everybody just kind of shows up with their own kind of ideas about what race is, and then it gets moved around in this very unclear way, which, I mean, for when I tell philosophers about this, right, their hair stands up because they spend all day thinking about a single sentence and like how, what happened. So they just, the people approach problems from such different areas. And I think that realizing that there really isn't a coherent, like, here's what the AMA says about race, or here's what, really a guidance for understanding people in populations, led me to understand that this was something that kind of needed to be worked on. Hopefully that's helpful.
That's great. Thank you so much. Let me turn to Geoff now, and maybe you could tell us a little bit about how your research informed your transition into policy.
Yeah, it's a great question. And I'll be honest that my sort of pathway on paper doesn't make a ton of sense. There aren't very many engineers in the policy realm. And it's also because there's not a lot of opportunities. But it really became clear to me during my research career. First was sort of looking at things like maternal mortality data and looking at things like the sort of usage rates of different forms of contraception across the world, and asking the question of just like, wait, why does my project need to exist in the first place, right? We have birth control drugs that have existed since the 1960s. We have all these different options. Most of them are bad in terms of like the side effects and things that they have. And many women would probably prefer to have more options, but they simply just don't exist. So it's asking the question, why does this project need to exist? Why was I, as an academic researcher, essentially, subsidizing the work of a pharmaceutical company? Why hasn't this research already been done before? And then undergoing the process of, considering trying to commercialize our product and say, okay, we think we have something here, let me put my money where my mouth is and try to make the change that I was hoping to see. And then realizing that, there isn't actually really a pipeline for developing new contraceptive products. There isn't venture capitalists out there ready to invest in women's health. They don't have the sort of the history of data. They've seen 200 cancer pitches, but they haven't seen reproductive health pitches. So they don't know what milestones to look for. They don't know what's important. And so simply, they just don't invest. And so recognizing that, the pipeline was completely dry, and realizing that, I could keep pushing from the academic side, but ultimately I'd be sort of essentially propping up a system that I felt was broken. And so I asked myself the question, well, how can I fix a broken system? And the conclusion I came to, whether it was right or wrong, was to enter into the policy realm to sort of, try to fix the pipeline, try to recognize the issues that I saw in my research and realize, oh, that happens in every field, particularly in the health research space. The things that are priorities aren't funded. The people aren't necessarily focusing on the things that I think to be important. And I wanted to change the conversation to the best of my ability.
Blair, I can't help myself. I need to jump in.
Please.
Geoff, I would argue to say from the research that I'm doing right now, that those VC companies and those pharma companies are not led by women. There's not even women on some of their boards. So therefore, reproductive rights is not on the radar because there are no women in leadership positions to care about. I guarantee you if that was to change and we had some equity in those types of components of the healthcare industry, that we would see more of those types of issues come to light because they would be asking those questions. So one, thank you for what you do. I just would argue again, we need leadership to have equal representation in order for those types of issues to rise to the surface.
And it seems like we need more women in the VC rooms as well, who are advocating for that as well, so that we've heard so much about different sides talking to each other about the issues that are important, and it seems like that's another place where the economics could drive this as well. We have a question from the chat that I would love to share with you all, and this. I will leave this for anyone who would like to take it. It is from Cyrita, and it says, with mental health, I feel that there is inequity across the lifespan on the comprehensive preventative measures that are taken. Do you think that health policy to get to a place where mental health could have equality to other areas of health where annual primary care psychology could be developed?
Yeah, some of that actually starts with health insurance plans actually covering adequately for mental health services. They continue to be carve-outs for years. And I think between healthcare policy and the health insurance plans is where it needs to start, because I think the delivery system is really passionate, or I can speak a bit for mine, we're really passionate about getting to more integrated behavioral health in our primary care. But so often we have to say, you know what, can you call the back of your insurance card and find out what you can do and what you can't do. And that leaves us constrained as a delivery system to be able to help patients in the ways that they deserve to be cared for. And unfortunately, it's just because mental health is still considered this separate thing instead of really understanding that it's part of the whole person. But
are
Jeff,
you seeing,
if you guys have other comments on that too.
Yeah, I would build on that, and absolutely payment parity is a huge portion of it as well. But I would build on that by also just saying the sort of public perception of mental health and what mental health looks like sort of, I think, needs to be radically rethought, particularly around like the criminalization of mental health and people suffering from, say, substance use disorders. That is mental health care, but it is oftentimes being administered by police. Or it's in prisons and places where, I wouldn't want to call a firefighter to cure my cancer. But unfortunately, those who are experiencing mental health crises are being turned to the carceral system for treatment rather than in their doctor's office. So payment and criminalization, or sort of the perception of criminal behavior associated with mental health, are, to me, the two biggest barriers and stigmatizers for getting true parity for mental health care.
If I may just talk a little bit about the social side, and also I think that it ties in nicely here that so Ian Hacking does obviously social constructionism, and I talked about race as a social construct, but he and his project does a lot with what was called at some point multiple personality disorder at the point that he was writing about it, and talks about how it changes and how public perceptions change. And I think that part of why a lot of mental health conditions can be pushed to the side or deprioritized is that a lot of them are kind of fall into this trap where they are enough social that I think physicians don't take them as seriously as these kind of more tangible physicals, right? If I can run a test and your level of X is really low, then I can feel a certain way about how imperative it is to get you care. But I think that just because of the nature of what mental health is, right? It is so connected to our social and environmental lives. We as physicians don't necessarily always get the understanding of race as of mental health conditions as physical and tangible and real and thus important. And I think that understanding socially constructed ideals or concept as real rather than imagined or constructed in a non-real way is also helpful.
So I have a follow-up question, and Sarita says, thank you all so much for your phenomenal comments on my earlier question. This question is because it is her passion to go into health policy to transform mental health care. And she asks, what advice do you have for her as she looks for a program? Oh, you're muted.
I was going to volunteer Geoff.
Ooh, okay. Ooh. It's funny because for the fellowship program that I'm an alumnus of, we're in sort of recruitment season right now. So I've been having a fair number of these sort of like career trajectory talks recently. Oh boy. What to look for in programs. So the thing that I always recommend to people who are sort of looking to go into policy is that oftentimes there's this duality that's expected from you, is that, you know, you're expected to have big ideas and to want to have radical change, but then at the same time, at the implementation level, you're expected to be very pragmatic and say, oh, we can only go like this little itty bitty step at a time. Mentally preparing yourself for that dichotomy and just sort of that recognition that like sometimes things go slowly and sometimes things need to go slowly is appropriate, but then also recognize that sometimes things are going slowly because people want them to, not because they need to. And I would empower you to sort of take big swings where you can. My motto in the healthcare policy space tends to be, you know, strong ideas loosely held. I don't know if that will help you in your journey. I'll just say that it's hard and I wish you luck.
That's great. Does anyone else want to add anything? I just speaking from my own graduate school experience, I would also say, you know, really look into all of the funding opportunities that you possibly can, just to make the practical side of your study and your life a little bit easier, or as easy as it possibly can. And also don't lose touch with your friends who are not in your graduate program, because as Geoff alluded to, graduate school is very intense and demanding and rewarding and wonderful, but it's also really lovely to have a connection with someone outside of your discipline, and especially someone that you've known for a long time. So that's just sort of a general tip. Then let's go back to a question from the chat. This is a question for all of the panelists. And Erin says, in your experience, what are some ways in which you have engaged the community in health policy making, whether that is through advisory committees or focus groups?
I can share first. Last year, I think everyone was aware of what was going on across the country when it comes to reproductive rights, and thankful, very grateful to live in a state like California where we have local policymakers who were really passionate about how they could step up in this way. When there was maybe some uncertainty at that point about what was going to happen across the U.S., and so being in healthcare, being asked to partner with our local community leaders as well as our state, legislator around what is it that we can do to prepare ourselves as a healthcare delivery system to bring in women from out of state so they can have access to reproductive rights. So that's the ways in which, I've been able to show up as, again, just being able to, again, advocate not just for the delivery system that wants to be able to be there for women, but also to be able to partner with community leaders, because it takes a village with every one of these health policy. You cannot do them in silos. I think Geoff had some really great examples earlier around, one problem or one solution, it seems really good to a community, but it actually can affect so many other areas. And unless you're looking at these problems holistically, with your policymakers, you could, again, fix one thing and break another inadvertently. And so I think that's the way in which I try to show up, is just making sure that, every collective voice in these focus groups or advisor groups that I've been able to be a part of is getting a chance to be representative and heard. So that way the policymakers know what they're doing, consciously or unconsciously, they choose to go forward with at least as much feedback as possible about those solutions. So
Super. We have another question from the chat. Mike, he says, thank you for all your efforts and commitment to making a positive impact on our communities, Triton style. And his question is from a big picture perspective. And he says, from your perspectives, is healthcare a service helping profession or a profit generating industry? What is being done at the larger level to give attention to this disingenuous consumer-based model and not adhering to the societal mission statement of medicine as a vehicle for wellness and individual and collective actualization?
Go, Imani.
Sure, yeah, I can comment. I think that, yes, first of all, it depends on who you ask, right? A lot of doctors want to serve and help and then get a lot of external motivation to do other things. And so I think that part of the problem, and also this, I want to tie into a question that someone else asked about like lung cancer screening and CT scans. So I think that really what we see, at least especially in primary care, is a medicine serving a gatekeeping function. Your primary care physician's role is to kind of figure out what's wrong with you in the cheapest possible way. And so that goes right to profit generation. In a sense, you're saying, right, we have to balance out these resources, and so we don't want to use them, frivolously. But what ends up happening, right, is that physicians have a lot of discretion over who then goes on to see a specialist, right? If your primary care physician never refers you to a specialist, then you may not uncover a problem until it's much further down the line. And now we have a health disparity that started with, right, a individual physician kind of gatekeeping the way to further testing. And so I think profit generation is part of it, but I also think that like something that gets elevated a lot of times above patient interest is cost saving, right? So making something cheaper rather than, giving something to someone that's cheaper rather than charging them for something that's more expensive. With how that might relate to a question that was asked about cigarettes and CT screening, it's definitely the case that CT screening is what's commonly used to, follow up on lung cancer nodules, and is can be an anxiety provoking. A lot of people end up with, odd things on CT that don't have consequences. I think this actually goes back a lot to what Geoff was talking about also. So increasing taxes on cigarettes is something that we've seen. It lessens the rate of smoking, right? But it doesn't eliminate it. It mostly just takes more money out of the pocket of lower income people and people who can't afford it. And the fact of nicotine addiction, I think, unfortunately, it's not really going anywhere. I think that we've seen this rebound, right, in electronic nicotine it's kind of left by this market, in this all this effort to take away cigarettes, right? It's kind of just created like a vacuum for like a new problem. And so part of the reasons, right, is you have to kind of go into the societal issues that cause addiction and cause people to become dependent on addictive substances. But there's also, right, vaccinations for lung cancer that are available in Cuba. Those was the ones were the first, I think, to an event. And so it's obviously not a perfect technology, but it's a technology that exists, but it's not globally available. And so just like what Geoff is saying, policy, international relations, right? We're all on the same earth, but we're not all in the same place because we don't share progress. And so when we don't share progress, a lot of times because of political and policy reasons. And so I think a lot of these problems really can be untangled in more effective and less harmful ways than things like tax increases.
Yeah, if I could just add, as the non-clinical administrator, so just the other perspective, because I think we get the most heat on running the business. So I'll just offer one to address the CT question. I think it's an and, not an or. I think you're absolutely correct that, you know, we need to swim upstream to solve most of these problems, but until we can fix them, to Imani's point, we need and, because CT is early detection, and let's get stage 1, stage 2 lung cancers, not stage 3, stage 4, which is what's current state today, right? And people are dying of lung cancer. It's the #1 cause of cancer death because we don't want to do low dose CTs. So it's not one or the other, it's an and, again, in my opinion. But back to my, thank you again for your question. I think it's probably one of the most thought-provoking questions I see all the time, and we have lots of robust discussion around. You know, I think as a healthcare delivery system administrator, it's really easy to say, well, if we just got rid of insurance, then, you know, the ugly green monster would be gone and we would all just deliver healthcare in an affordable way. But we know what other countries look like who do that model. And there's pluses and minuses to every parts of those things, right? We don't want patients waiting 6 months to receive, you know, care because they're in that more socialist model. But in the same token, right now, most of the barriers that exist for us to be able to deliver the care the way it should be at a affordable rate, or even let's call it a free rate, you know, to patients, it's disincentivized because of healthcare policy and because there's too much money in the pockets of the people who need to be making the decisions. We'll just leave it at that so we don't cause too much of a political debate. But I think to Imani's point, more clinicians and more healthcare workers would be able to do what they really want to do every day when they come to work if there wasn't too many disincentivized systems in place right now for us to do that. So
thank you. I think it would be really interesting to hear from anyone who would like to take this about what was most surprising in your work, in your research.
Mine was something that, oh, sorry.
go, Imani.
Something that I already talked about, which was the perplexing way that race is conceptualized in medicine. I think that obviously we all have a lot of trust and faith in our doctors, as we should, but we don't a lot of times think about what can be happening upstream of our doctor, right? Like we have a very personal relationship with our doctor. That's like our doctor, right? But like the doctor went to medical school, and medical school is there's a lot of standardized information, right, that comes through medical school, and that can sometimes not be accurate. And you know, you get this. You have a doctor who went to medical school, and you know, a few decades ago, a doctor who went to medical school more recently, and there's disagreement about best practices and things like this. This kind of stuff happens all the time because medical education is staggered like that. And I think that, yeah, it was surprising to me the things that were missing from a medical understanding of people and race in particular.
I will just share real quickly, just because I'm in the middle of my research right now, that the few ahas that I have, I'm sure I'll have more in about 45 days, have really been about the stories we tell ourselves, the paradigms that we come into each of these research problems with, and our own experiences. Obviously, as a healthcare administrator who is a female, I have my own experiences that I had to kind of check at the door coming into the research. But just hearing from the few research participants who have been able to interview so far, my aha has been, it's actually some of the really simple behaviors that get in the way. They're not these big, huge tackling problems. It's things like, you know, a male leader standing in front of a room and saying, hey, next week at that board meeting, I expect everyone in a suit and tie, but there's 3 ladies in the room. Are we addressing what they're supposed to wear? Or, you know, it's standing in front of them and basically saying, you know, it's okay that we can be in khakis and polos this Friday because we're going to go hit a bucket of balls. And it's just this vernacular and this very, what I would call basic conversation, and these things that show up that implant in a woman's mind, well, I'm not part of that, or I don't look like that, or I don't represent that. And in our industry, like I shared earlier, if 75% of the workforce is women, but they don't see women leading the company because they're only allowed to move up in nursing or HR or marketing or some of these traditional female roles, then they don't, again, feel like they're led. And I think we see that in all different types of healthcare research, and really all types of research. It's about representation. It's about seeing people who look and think like you in order for you to want to move forward in that space. So that's been an aha for me, is that it's actually more simplistic and less complicated than I thought. And again, maybe we'll solve it one day.
As a white guy from Canada who was researching birth control for women in sub-Saharan Africa, I will say that every aspect of my research surprised me. And every day was a learning opportunity and realizing all the things that I didn't know. Sorry, I don't know if you can hear my phone ringing, but great timing. I will say, and I spoke a little bit about sort of the surprise I had in the system and brushing up against it. But the one thing that I would say surprised me the most, or a thing that surprised me a lot about sort of discussing my research, is a lot of times the questions I would get is like, why are you doing this? Right? And this idea that only women or only women from sub-Saharan Africa should be the ones doing the research to help certain populations. And I absolutely appreciate that they should be the ones leading the discussion, and they should be the ones, you know, telling me what's important and what are the criteria that I should be hitting, because those are their lived experiences. But at the end of the day, there's also a huge emotional burden that goes on with, you know, I'm the only person that can solve this. If I don't do this, no one else will. You know, I don't think that only men should be researching prostate cancer. I don't think it would be weird if I was researching breast cancer. But there was this weird stigma and sort of discussion around like, well, why are you the person doing this reproductive health project? And, you know, I'm glad that my mom had access to reproductive or family planning services. You know, I benefit from having more women in the workplace and having more women in senior leadership roles. You know, I benefit from that. So I should give back. I should help people no matter who they are. I should use the skills that I have to help. And I think that was a really interesting sort of perspective that people would have when I told them about what I did. And really sort of surprised me, but not necessarily in a positive way.
Well, we are so fortunate to have you all doing the work that you do, and we benefit from your expertise, and especially this afternoon. And I know that our futures will be shaped by all of the work that you're doing. So we thank you so much. And I want to remind everyone that this conversation on equity in healthcare will continue tomorrow in person down at Park and Market. But huge thanks to everyone for coming out, and especially to our panelists.